Shall we start? Hello.
Yes, sir.
Yeah,
Yes, sir.
So, okay, we're going to start. Very good morning. So the parts which we have covered are like till now number 1, 2, 3, 4, 5, 6, 7. 3 things which you are supposed to cover. So maxilla, mandible, and lip are remaining. Okay, so probably we'll cover 2.5 of these things, and then rest half of the lip will be covered in the next class. Okay, first one we were covering about the buccal mucosa. Next is floor of the mouth. Next is retromolar trigone we have covered, and tongue we have covered. So all these things are done till now as far as the cancers of the oral cavity are concerned. Most of the important thing for this is tobacco chewing, and then smoking, and then alcohol. Most of them they present at an older age group only. Okay, so all of them are no less common except for this buccal mucosa, along with the alveolo-buccal complex is most common in the case of India. You should keep it in mind. And then you know about the anatomies of most of the things, and maxilla, mandible, and lip are to be covered this class. So maxillary alveolus. So when you take especially maxilla, as we have seen that it is six-sided bone, and you have got anterior, posterior, okay, medial, lateral, superior surface, and inferior surface. These are the surfaces of this maxilla, wherein especially when you take this alveolus, so maxillary alveolus, so you have it like this along with the upper jaw teeth. 7, 8. Okay, 1, 2, 3, 4, 5, 6, 7, 8. So this alveolar process is the one wherein the teeth are present in the maxilla. So here will be the tuberosity and here will be the tuberosity. So teeth are present in the maxilla, and the one which is there in the middle is called as hard palate, as you know. The one which is there in the middle is called as hard palate. So maxillary alveolus is this one with teeth and hard palate. The hard palate is the center one. So the osseous alveolar process supports the maxillary dentition. So wherever there is AP, so alveolar process, it supports the dentition. So take the maxilla, wherever the tooth sockets are there, that is called as alveolar process. This process is called as alveolar process. And it is covered by mucoperiosteum with a stratified squamous epithelium. As you know, oral cavity most of the times, wherever there is food that is getting attached to that particular mucosa, there will be keratinization. Of course, keratin will be more here, unlike the buccal mucosa. So stratified squamous epithelium, mucoperiosteum. So the maxillary alveolus merges laterally with the buccal mucosa and lips at the gingivo-labial sulcus and medially with the hard palate. So when you take in the forward view, this is the, for example, teeth. These are teeth from the front. You are seeing the teeth from the front, and this is the alveolar process. And this is the alveolar process, as you could see here. And this is the alveolar process. Here the teeth are attached to this on this side and this side. And you take once again the the cheek. This is the cheek, for example, on this side and this side. So what does this form? This becomes the gingivo buccal sulcus. Gingivo buccal sulcus. So this is the lateral boundary where the gingivo buccal, gingiva and this teeth will be joined at the gingivo buccal sulcus laterally. And the same way, when you take it anteriorly, you have got the lips here. So you have got the lips here. So you should be having the lips here. And the one which are the teeth which are there over here, for example, like this, I'm telling you. And then this could be called as gingivo-labial sulcus. So this particular part will be called as gingivo-labial sulcus. So from between the lip and this particular teeth. Okay, gingivolabial sulcus. So where does this alveolar process extend from to the upper end of the pterygopalatine arches posteriorly? So when you take this, for example, this maxilla like this, so this upper jaw like this, for example, so these are the alveolar processes where teeth are present, extend to the upper end of the pterygopalatine arches posteriorly. So from behind, if you see, there will be palatine bones, perpendicular plate of palatine bones like this. So and then this is horizontal plate of palatine bone. So you are looking the nasopharynx from behind, and in front will be your at this part will be your so palatine process of the maxilla. So this will become the upper jaw anterior part, and this will become the upper jaw posterior part looking from behind. So upper jaw anterior part and posterior part looking from behind. So this will become the anterior part of the upper jaw. This becomes the posterior part of the upper jaw. So this is a palatine bone horizontal plate, and this is a vertical plate of palatine bone. So where does this alveolar process? If you take the alveolar process, if you lift it up and then see, you find the alveolar process like this. Is it or not? If you lift the bone and reverse and see the skull, find the alveolar process like this. Upper end of the pterygopalatine arches. So what is the pterygopalatine arches? So once you say this part belongs to horizontal plate of palatine bone, this part belongs to maxilla. So and behind, if you go, there will be pterygoid plates of the sphenoid. Pterygoid plates of the sphenoid. So this particular posterior part becomes the pterygopalatine arches posteriorly. So this posteriorly it becomes the pterygopalatine arches. Posterior part of the alveolar of the maxilla is called as pterygopalatine arches. So and where is the hard palate? Hard palate is lying within the horseshoe shape of the maxillary alveolus. If you take this as the horseshoe shape of the maxillary alveolus, I already drawn here. This becomes the hard palate. This becomes the hard palate. So hard palate becomes the hard palate. So hard palate is formed by palatine process of the maxilla. This is the palatine process of maxilla. This is the horizontal plate of palatine bone. There is perpendicular horizontal plate of palatine bone, and behind will be your pterygopalatine arches. So merging imperceptibly with the alveolar mucosa. So if you take this as a tooth, for example, and then this is the maxillary bone. Tooth is there like this, so this becomes a hard palate. This becomes a hard palate, merging imperceptibly with the alveolar mucosa. This hard palate, it merges here. This becomes a hard palate and merges with the alveolar mucosa. That's what is being said. And the specialty of this is that the hard palate has got minor salivary glands located in the minor salivary glands. There are a lot of minor salivary glands located here. So minor salivary glands located, and this is the hard palate. There are a lot of minor salivary glands, and in the submucosal region, and 33% of the palatal tumors are derived from the salivary epithelium only. So hard palate has got a lot of minor salivary glands. This is minor salivary. It's not major salivary gland. Minor salivary glands. All over the upper aerodigestive tract, there are nearly 1200 minor salivary glands. Nearly 1200 minor salivary glands. So they are distributed. Therefore, 1/3 of the maxillary tumors or palate tumors are salivary gland tumors. So 1/3 of the palate tumors are salivary gland tumors. And as the size of the salivary glands decreases, malignancy increases. The malignant potential increases. As the size of the salivary gland increases, malignant potential increases. Posteriorly, the hard palate merges with the soft palatate edge of posterior edge of palatine bone, as I already told you. So when you take this is the hard palate, this is the alveolar process, and this part becomes the palatine process of maxilla, and this part is nothing but your horizontal plate of palatine bone, and behind it will be your soft palate. So behind it will be your soft palate. So this is a soft palate. So this is how these classes are most commonly helpful for you to understand the anatomy more commonly. This oncology is not very important for you, but you should understand the anatomy. Then you will be able to understand big things later on. The sensory innervation of the maxillary mucosa is by means of branches of maxillary division of the trigeminal. So trigeminal was ophthalmic, maxillary, mandibular. So this is maxillary. Maxillar is to maxillary division of the trigeminal, as you know that. The nasopalatine nerve supplies the anterior hard palate passing through the incisive foramen. So once again, if you take the hard palate like this, so there will be two foramen here. So this is called as nasopalatine nerve supplies the anterior hard palate. Anterior hard palate. This is a nasopalatine nerves that come like this. So these are called as the nasopalatine nerves. For here will be the incisors. Is it or not? Here will be the incisors, and through the incisive foramen. So this is called as incisive foramen. This foramen is called as incisive foramen. Incisive foramen. And the posterior palate, if you take the posterior part of the palate, it is divided into anterior and posterior, being supplied by greater palatine nerves. So the greater palatine nerves will be coming from here to the greater palatine foramen. The greater palatine nerves come through greater palatine foramen. Greater palatine foramen. Greater palatine nerves come through greater palatine foramen. Greater palatine foramen. These are the greater palatine nerves through greater palatine foramen. Lymphatic drainage is to the ipsilateral cervical nodes, especially the submandibular nodes and retropharyngeal nodes. So I told you during telling the maxilla carcinoma of the maxilla, that is in the nose, they go into the submandibular nodes. So from the maxilla, they drain towards the, if this is the mandible, they drain towards the submandibular nodes. The maxilla, they drain to the submandibular nodes. Submandibular nodes. Maxilla, they drain to the submandibular nodes. From the maxilla, they drain to the submandibular nodes. Submandibular nodes. So especially when you think about this maxilla, so upper jaw is nothing but maxilla. Maxilla is going to form upper jaw, and it is going to form tumors of the maybe hard palate or tumors of the nose also. Okay, you should understand that maxilla has got maxillary sinus in it. So below that will be the teeth. So this part will be the bone part which is having tumors of the upper jaw, and this part will be the tumors of the maxillary sinuses or nose. It is also forming the nose. So you should have idea about both of things. As you know, it is squamous cell carcinoma of the maxillary alveolus. So maxillary alveolus. That's why we are discussing about the maxillary alveolus. It is a bit rare only. That is almost 6.5%. Almost 6.5%. Okay. And of the oral cancer, the total of the oral cancers, it is rare. Okay, 6.5%. Being approximately 1/3 as common as mandible. So mandible is more than maxilla. Whenever you take the tumors, mandible is more than maxilla. Mandible is more than maxilla. Mandible is more than, this is a mandible, you should remember like this, and then this is the maxilla. Mandible is more than maxilla. So mandible is more than maxilla. So in the same way, men are more than females. Males are more than females. So you should say carcinoma of the hard palate is very unusual, presenting only 1 to 3%. Especially if you take hard palate, 1 to 3%. It is maxillary alveolus 6%, and hard palate is 3%. So when you take maxilla as a whole, so this alveolar carcinoma is more common, and hard palate is less common. This is 3% only, and this forms the 6%, almost 6%. So especially hard palate tumors are nothing but your minor salivary gland tumors, minor salivary gland tumors. Hard palate tumors are nothing but your minor salivary gland tumors. So you should keep it in mind. Hard palate tumors are nothing but your minor salivary gland tumors. Palatal carcinoma is particularly associated with reverse smoking. So if you take tobacco, alcohol, I already told you. Palate reverse smoking, especially this is Srikakulam and Vijayanagaram districts of Andhra Pradesh. Okay, they are very important. Srikakulam, ladies will be reverse smoking. Srikakulam and Vijayanagaram. Of course, it's not given in the textbook, but it is a known fact. Okay, especially it is more common in Srikakulam and Vijayanagaram districts, especially Indian women, that is coastal Andhra, especially Srikakulam and Vijayanagaram region. They have the habit of reverse smoking. They put the lighting end inside the mouth. They put the lighting end of the cigarette inside the mouth. They smoke like this. Ulta smoking, reverse smoking. They are in 6th to 7th decade, most of the time 70 years, 60 years only, and even distribution between the sexes. So sexes, almost even distribution is there. Especially mandibular carcinoma, more common in men. Okay, but maxillary carcinoma you can take equal distribution, male equal to female, almost equal. So maxillary it is male equal to female, but mandibular, as I told you, it is in men, it is more common. But reverse smoking, as you could see here, it is more common in females. Reverse smoking is more common in females. How do they present? They present with pain. Number one, they present with pain. Number two, they present with ulcers. Number three, they present with loose teeth. Number four, poor fitting dentures. Old people, poor fitting dentures. Teeth are loosened because alveolus is there, teeth is there, teeth are loosened, ulcer can be there, pain can be there. Advanced diseases. What are the symptoms of advanced disease? Number one, infraorbital paresthesia. Number two is trismus. Number three is nasal block. Infraorbital paresthesia. Next, trismus. Next, nasal block. Infraorbital paresthesia, trismus, and nasal block. So, trismus is because of masticator space involvement. Trismus is because of masticator space involvement. Infraorbital paresthesia, as you could see, if you take this is the maxilla, so maxilla and this is the cavity like this, and then this will become the orbit. This becomes the orbit. So this is the infraorbital foramen. Below the infraorbital foramen, there will be an orbit below the nerve coming called as infraorbital nerve. It is called infraorbital ion. So this can go to this side. The tumor can go to this side and then can form infraorbital paresthesia. Infraorbital paresthesia, very important this one. And most patients present with stage 1 and stage 2. As you should know, stages of the disease is very important. Stages of the disease is very important. I was keeping on telling you. Once again, I'll try to tell you T1, T2, T3, T4. Should write like this. And N0, N1, N2, N3. And you should try to write another way that so 1, 2, 3, 4. Okay, this is T1, T2 is like that, and you write 3, 3 here, and rest all you write 4. Rest all you write 4. You will get the staging of the diseases very easily, simply, very easily. So T4 N0 is stage as 4. Okay. So T4 N1 is stage 4, T4 N2 is stage 4, T4 N3 is stage 4, something like that. So T1 N0 is stage 1, T1 N0 is stage 1. You should get the staging like this. Staging of cancers is done like this. You should keep it in mind. Most patients present with stage 1 or 2 disease, and 80% of patients present with of hard palate and maxillary alveolus present with cervical lymphadenopathy. Cervical lymphadenopathy is very important here. What are the lymph nodes that are present? Submandibular lymph nodes and retropharyngeal lymph nodes. Imagine, so this maxilla goes to submandibular region, very important. We'll be shocked to see why it goes to submandibular. The distribution is like that. Submandibular or number 2, it will go to retropharyngeal nodes. Submandibular or retropharyngeal nodes. It goes to submandibular or retropharyngeal nodes. 27% has got occult metastasis, sudden metastasis. So lymphadenopathy is towards the submandibular region. You should remember that. Workup. The surface extent of the maxillary carcinoma can be relatively easy to determine from clinical examination alone. Okay, surface you can see by clinical examination only. Of course, maxillary antrum, if it is involved, you need to go for CT scan. Okay, antrum, that is, if it is going towards the maxillary sinus, then you have to go for CT scan. Extension of tumor to the pterygoid plates and masticator space is inoperable, becomes T4B. Pterygoid plates and masticator space is inoperable, T4B. Inoperable. I'll tell you once again the staging after the completion of maxilla and mandible. So T4B, as you could see. So when you have, for example, maxilla and mandible, for example, T4, how it comes like, so when it is going to skin of the cheek, or as you could see, so infraorbital nerve paresthesia, okay, skin of the cheek and deep extrinsic muscles of the tongue, all this come under T4A. T4A, whereas T4B is the tumor is spreading to pterygoid plates of the skull base, or it can spread to masticator space, or it can spread to, as you could see, or it can spread to internal carotid artery. So that will be, I'll be showing you once again after the completion of this. So you need to have CT scan and MRI, which are complementary for maxillary tumors. So because maxilla is related to nasal cavity, you should do endoscopy of the nose also. Nasal endoscopy should be done. Whether floor of the nose is involved or not. Antral wall is involved or not. Whether antral wall is involved or not, you should be doing that. So you should take for a temporary obturator and free flap also when you are trying to reconstruct. So when you are removing, when you are doing, when maxilla is involved, you have to go for maxillectomy. Like I told you in the nose cancer itself, you have to go for maxillectomy. Once the defect is produced, once, for example, one maxilla is removed, you have to put some obturator. It is called as obturator. It is called as obturator to fill up the gap. Obturator to fill the gap. So you have to go to a prosthodontist. Prosthodontist. So you have to go to a prosthodontist to take a cast. You should take a cast with the POP, and then you have to prepare a obturator. Obturator. When you are removing a tumor, you are left with the space. You have to fill it with obturator. It is also called as gutta percha process. I told you already in the nose. Gutta percha. Gutta percha. In the unfortunate situation of pre-flap failure, the presence of pre-surgical modes, like you have to go for a prosthetic reconstruction also. It is easier for prosthesis, and second thing is free flap. You are going to go for free flap. If it fails, you can go for prosthetic reconstruction. So I already told you prosthodontist is very important for handling the teeth. Anesthesia is accomplished with an oral tube. If you want to do maxillectomy, sometimes you have to go for tracheostomy also. Tracheostomy, if the resection is larger, and if you want to put a free flap, tracheostomy is also considered. So sometimes, how do you? So I told you already, for a surgery of cancer, you have got resection. Number 2 is reconstruction. You have to replace the tissue. Number 3 is rehabilitation. Resection, reconstruction, rehabilitation. These three things are to be done. So you have to reconstruction. How is it done after resection? Upper cheek flap with a blood vessel, and the eyes are protected, and corneal shields are temporary tarsorrhaphy. So because this is the eye and this is the maxilla, is it done? When you are removing the maxilla, your eyes get damaged. Therefore, you should suture these two layers of eyelids. That is called as tarsorrhaphy. Temporary tarsorrhaphy, and later on you can remove the suture so that eye is spared. That is called as temporary tarsorrhaphy. The surgical goals of heart, palate, and maxillary alveolus tumors are same as other sides. What is this margin that you should keep? If this is the tumor, you should leave 1 centimeter more margin. 1 centimeter more margin. I already told you this before. If the tumors are small, you can remove perorally. Through the oral cavity itself, you can remove. However, larger tumors, you need to go for upper cheek flap and midfacial deglowing. So what is midfacial deglowing? Upper lip, for example, upper lip, this is the upper jaw. So you have to take incision from maxillary tuberosity to maxillary tuberosity. This is the upper lip, I told you. So you have to take incision from maxillary tuberosity to maxillary tuberosity, and you have to go like this. So there will be nasal aperture here. You will be going up and up like this till the level of orbit. So this is called as midfacial deglowing. Like old generation movies, they wear a mask. So you have to remove this facial skin like a mask. Once the mucosal incisions are completed, they are lifted in a subperiosteal plane. I already told you when it was done in the case of nasal tumors. In the nasal tumors, I told you subperiosteally, and you have to remove the bone with bone cuts. Sometimes teeth are to be extracted, and they are called as osteotomy cuts. There are 6 osteotomy cuts. Okay. For maxillectomy, how many cuts are there? 6 osteotomy cuts, which I already told you when I was telling the nose. The use of fine reciprocation, you can use a sagittal saw. Saw allows the cutting of bone. Care should be avoided to avoid the roots of the teeth. Tooth roots should not be damaged. Tooth roots should not be damaged. Tooth roots should be carefully protected. The margins of the resection extend posteriorly till the level of pterygoid plates. Okay, pterygoid plates. As I already told you, if you are cutting the maxilla, the posterior border will be your this horizontal plate of palatine bone, and later on will be your pterygoid plates. So your cutting should be proper. Pterygoid plates with a curved osteotome. Posterior dissection is completed by large curved scissors. So these are all not very important things for you, but completion sake I am telling you. The posterior dissection in the pterygoid region, there can be a chance for bleeding because different arteries, pterygopalatine fossa, there can be very important branches of the maxillary artery can be there. They can lead to bleeding. So once coronoidectomy is also used to minimize the impingement of coronoid and the prosthesis. Coronoidectomy. What is coronoidectomy? So this is the mandible. This is the coronoid process. So when you are removing the maxilla, you have to do the coronoidectomy also for prosthesis placement or flap reconstruction. Defects are reconstructed by split skin graft. So various methods of reconstruction are there, of which split skin graft or composite grafts can be there. For small maxillectomy defects, you can achieve with local flaps such as buccal fat pad. Buccal fat can be taken. Temporalis flap can be taken. Facial artery myomucosal flap. Facial artery myomucosal flap. It is based on facial artery. You can put it like that. For larger defects, what would you do? Soft tissue or composite free tissue transfer. Okay, like fibula transfer. Fibula is useful for that. Okay, radius is useful for that. You can use that bone along with some soft tissue. The use of appropriate defect classification system is there. Of course, this is not into the details of this chapter. So defect classification of upper jaw is there. For PG level, it will be told. So how would you manage the neck? So regional spread from maxillary tumors. So hard palate, alveolar tumors and sinonasal tumors, they are nearly 35% of the patients. Okay, 35% of the patients. And what is the lymph node level? I told you submandibular lymph nodes is involved and retropharyngeal lymph nodes. Of course, retropharyngeal cannot be removed. Submandibular, that is level 1 to 3 elective neck dissection is done. 1, 2, 3 elective neck dissection is done. Level 1, 2, 3 elective neck dissection is done for lesions of T2 or greater. For lesions of T2 or greater, if it is more than T2, that is 2 to 4 centimeters, more than T2 or 2 to 4 centimeters, you have to go for a elective neck dissection. More than T2 to 2 to 4 centimeters, more than in between 2 to 4 centimeters of size, you have to go for neck dissection of level 1, 2, 3. 1 is submental, submandibular, 2 is upper jugular digastric, and 3 is omohyoid. So 2 to 4 centimeters itself, you have to go for 1 to 3 level lymph node dissection. Class consideration should be given to clearing the facial lymph nodes when conducting the neck dissection for maxillary tumors. So you have to think about the facial lymph nodes also for maxillary tumors. Facial lymph nodes also should be thought of. When will you give postoperative radiotherapy for T3 or greater disease? T3 is more than 4 centimeters. T3 is more than, once again, remember T1 is less than 2 centimeters. T2 is 2 to 4 centimeters. T3 is more than 4 centimeters. And T4 has got T4A and T4B. Okay, T4A, once again, if you take, you have to say, if it is upper jaw, you have to say that it is going to the level of bone of the maxilla that is there. It is going towards the inferior orbital nerve, and then it is going towards the deep extrinsic muscles of the tongue. And T4B is masticator space, and then also your pterygoid plates, and also your skull base, and also your internal carotid artery. All these things are all T4B. So when you have got T3 more than T3, these all patients should have postoperative radiotherapy. These all patients should be given postoperative radiotherapy. Postoperative radiotherapy can be given. What are the indications like positive margins? If the margins are positive, there is perineural spread around the, as you could see, infraorbital nerve. I told you, any nerve spread is there. It is spreading around the nerve, or perivascular invasion, any blood vessel related perivascular invasion. Perivascular invasion is there, or multiple cervical lymph nodes. Multiple cervical lymph nodes are there, you can go for it. An extracapsular spread is there, you can go for it. Extracapsular spread, very important. Postoperative radiotherapy is done. And recurrent loco-regional control. This is local regional control. And hard palate and alveolar tumors, and 40 to 45%, they need the postoperative radiotherapy. So once increasing to 68 to 68% following secondary intervention. So once, if it is not going to be done, it is going to increase to 68%. Therefore, postoperative radiotherapy is a must for this. Salvage is achieved in 33% and regional recurrence in 71% when you do post-operative radiotherapy. Over 90% of recurrence occurs within the first 2 years. First 2 years, 90% of the cases they recur in this site, that is mandibular maxilla. 90% they recur. The prognosis is 57% and 5-year survival rate is 49%. These are all just figures which you need not remember, but half of the cases they have got 5-year survival rate, they can live for 5 years minimum, and then 49% for this alveolar carcinoma. Tumor stage and cervical metastasis. So long-term survival is based on stage of the tumor and cervical metastasis. Cervical metastasis. For any tumor, if cervical metastasis is there, the prognosis becomes 50%, becomes half. Cervical metastasis is there, the prognosis becomes 50%. Very important. The prognosis becomes 50%. Next, the second part of discussion for today is the mandibular alveolus. As you know, the mandible has got condyloid process. This is the coronoid process, and this is the angle, and this is the angle, and this is the body. So this is the symphysis menti. This is the symphysis menti. This is the symphysis menti. You have got a mylohyoid line towards medially, and you have got socket for teeth over here. Socket for teeth over here. 1, 2, 3, 4, 5, 6, 7, and 8. So 1, 2, 3, 5, 6, 7, and 8. So you got socket for teeth like this. And in front of this will be your retromolar trigone region. As you know, this is the retromolar trigone region, and this will become your anterior pillar and then posterior pillar. This will become anterior pillar and posterior pillar, and this becomes a soft palate. So this, and you have got the inferior alveolar nerve and vessels going like this. So coming like this outside with the mental foramen to the mental foramen, the inferior alveolar nerve goes and comes out like this. So inferior alveolar nerve involvement is very important for considering the mandible. And you have got the this is the condyle, this is the coronoid process, and then this is the angle, this is the ramus, and this is the body of the mandible. These are the parts of the mandible as you should be able to know. So now we are discussing about this alveolar process of the mandible cancer. The mandibular alveolus, it represents a part of the mandible that is there intraorally. So intraorally. So when you say intraorally, if you take the mandible, once again it looks like this from above. Okay. So this particular part is called as alveolar process. Whichever is there intraorally. That is, if you take this is the tongue, this becomes the floor of the mouth, and this becomes the intraoral part. So this part is being the intraoral part. So intraoral part of the mandible, as you can see here. So the osseous, hello, is it audible? So the alveolar process, as you could see here, this is the alveolar process, which is supporting the dentition along with the mucoperiosteum. When you say this is the floor of the mouth and this is the tongue, for example, this is the tongue. So this has got teeth here. Teeth is there here, and then mucoperiosteum goes upwards like this, and then comes like this. And this becomes the cheek. This becomes the cheek. So this is called as the gingivo-buccal sulcus here. So anteriorly, this will become the lip, and this will become the gingivo-labial sulcus. So this is the gingivo-buccal sulcus on this side. So this is the tongue. So mandibular alveolus merges laterally with the buccal mucosa lips and gingival sulcus, and medially with the floor of the mouth. So this is the floor of the mouth. So this is the alveolus of the mandible. You can see this is the alveolus of the mandible. So this is how the alveolar process extends to retromolar trigone. I already told you this is the alveolar process that is over there. Here is the retromolar trigone. Take the mandible, this becomes the retromolar trigone posterior. Sensation is by the mandibular alveolus and mandibular division of the trigeminal. Mandibular alveolus and mandibular division of the trigeminal nerve. So this is Ophthalmic maxillary mandibular division of the trigeminal nerve. This becomes the division of the trigeminal nerve. The lymphatic drainage is to submandibular lymph nodes. Submandibular lymph nodes and submental lymph nodes and deep cervical chain. If you take the mandible like this, you've got submandibular lymph nodes. It goes towards the submandibular region or submental region, and it goes towards the neck region like this. Okay, it goes towards the neck region. Midline is always bilateral. Any midline structure is bilateral. Any midline structure is bilateral. Any midline structure is bilateral. Just a moment, please. Hello. Hello.
Yes, sir.
Yeah. Am I audible?
Yes, sir.
Yeah. There was some disturbance. They have changed the position there for small time, small break. The midline structures are bilateral. As you could see, these are the bilateral distribution will be there. Any midline structure will go to the bilateral. That should be mind. Following the loss of dentition, if dentition is lost, there is a resorption of the alveolar process. Alveolar process, this is the teeth, then you have smaller structure compared between the floor of the. Hello. Am I audible?
Yes, sir.
Okay. There was a small internet connection problem. So then, how do you say the epidemiology? Squamous cell carcinoma. Once again, squamous cell carcinoma. This is also a bit rarer, but a bit more common. As I already told you, 7 to 15 or 17%, you can say. So mandible is more common than maxilla as far as the tumors are concerned. So it presents about 30% in Japanese population. Japanese, it is more common. So mandibular tumors are almost more common in the case of Japanese. So mandible, as I already told you, it is 3 times more common than maxilla. So mandible is more than maxilla. Maxilla is lesser. Sometimes intraosseous carcinoma, that is the tumors of the bone, also occur in this odontogenic epithelium, that is the dental tissues within the mandible. That is one problem here. So dental tissues also can cause some cancers, okay, like ameloblastoma, etc., etc. I'm not going to details of that. So that is also there in this particular mandible. So tobacco, chewing tobacco and alcohol considered to be a parts of this. So they present later in life in the 7th decade. Any patient, most of the time 60 to 70 years only. Okay, 40 to 70 years is the presentation for oral cancer tumors. And more common in the males. So in maxilla, male equal to female, but reverse smoking is more common in females. But in mandible, male is more common. Okay, mandible male is equal to more common. In maxilla, male equal to female, except for reverse smoking, which is more common in females. They present with pain and loosened teeth. Teeth can be loosened and difficulty in fitting the dentures. That is also presenting complaints. They present with labial paresthesia. So inferior alveolar nerve, if it is lived, and then I told you the inferior alveolar nerve comes out as a mental nerve. If mental nerve is damaged, paresthesia of the lip. They have paresthesia of the lip. This is the presenting complaint of this lip tumors. Unfortunately, delayed healing also there in the case of extraction. If teeth extraction is done, there will be some delayed healing in some persons along with this carcinoma. That is also a presenting feature. Delayed healing is an important factor. So majority of the lesions of the mandibular alveolus, they are located posterior to the canines. So behind the canines, it will be there. If this is a canine here, behind the canines, there will be tumors. This floor of the mouth or buccal mucosa being more common. So they are nearer to the floor of the mouth or buccal mucosa. I told you alveolar buccal complex is the most common site in the oral cavity. So alveolar tumors are staged until their invasion of the tumor. So you can say cortical bone involvement or marrow. So bone that is there, cortical bone or marrow, bone marrow involvement, tumor becomes 4A, T4A, as we know that. Lymphadenopathy is present in this 24 to 32%, and level 1 and 2 are involved. Level 1 is submental, submandibular. Level 1 is submental and submandibular. And level 2 is upper jugulo-digastric, like tonsil node. Okay, upper jugulo-digastric node, tonsil node, upper jugulo-digastric node. Some 15% will have occult metastasis, sudden metastasis without any evidence of primary tumor. So 94% will have evidence of bone involvement clinically. Sometimes bone involvement is there clinically. Why? Because mandible is more commonly involved than maxilla. I told you bone involvement they present directly. Sometimes they involve the bone and then present directly. They have to go for mandibulectomy. Okay, mandibulectomy you have to do. Most tumors are well or moderately differentiated. Well or moderately differentiated. So based on differentiation, well differentiated, moderately differentiated, poorly differentiated, and anaplastic. These are the 4 types of differentiation I told you. Well and moderate are good one. Poor and anaplastic are bad one. These are good one and those are bad one. So degree of bone involvement. So when mandibular tumors are there, degree of bone involvement is very important. Degree of bone, how much bone is involved and what is the extent of tumor resection, whether bone has to be removed or not. So two types of bone removal is there, rim mandibulectomy and segmental mandibulectomy. So when you are removing a segment as it is called a segmental mandibulectomy, and you are removing a rim of a tissue, then it is called as rim mandibulectomy. When you are removing a rim of a tissue, it is a rim mandibulectomy. This is a rim, only a smaller rim, like a cycle rim, a small part of this one is removed. That is called a rim mandibulectomy. So how would you treat this? Primary, it is a surgical disease, definitely a surgical disease. You have to do surgery. Bone resection is definitely required because 94% of patients will have some bone involvement. Bone resection is required, and 6 to 7% only they have soft tissue resection. So out of 100 patients, you have to remove the bone in 94% of the patients. Rest all only soft tissue. Smaller tumors, that is T1, T2, with no evidence of bone involvement. If bone is not involved, intracavitary, intraorally, you can go for marginal mandibulectomy. So rim is also called as marginal mandibulectomy. Rim is also called as marginal mandibulectomy. Rim mandibulectomy or marginal mandibulectomy. 1 centimeter is the bony margin required. 1 centimeter is the bony margin required. Larger tumors, they require segmental resection. If large tumor is there, you have to remove the segmental resection and extraoral access incision. You have to go extraorally. Outside incision you need to give for it. So larger tumors, segmental. So when you take mandibulectomy, these concepts are only just for your facilitating your understanding because you have got time and I'm trying to go into it. If not, they are not needed directly to you. But you can just write the word segmental mandibulectomy and the marginal mandibulectomy. They come for 2 marks or maximum 4 marks. They won't be given for essay in the undergraduate level. So what is segmental resection? Small tumors abutting the mandible previously treated. When will you do segmental resection? Segment is removed completely. So when previous radiotherapy is given, our massive soft tissue tumors is there and inferior dental nerve. So inferior dental nerve is there, they have to do that, and intraosseous tumors within the bone. If the tumor is there, then you have to go for it. So segmental resection is done in such situation. When you do marginal mandibulectomy, so preferable to segmental mandibulectomy. Whenever you can oncologically safe margins, you can remove. It is a small resection. Marginal mandibulectomy is a small resection. This is a large resection. This is a bigger one. This is a smaller one. Reconstruction is achieved by primary closure. You need not put any flap is not needed in this, or any graft is not needed. Graft is not needed for marginal mandibulectomy. When extensive mucosa is involved, you need a skin graft, as I already told you. Local flaps like facial artery, myomucosal flap, facial artery, myomucosal flap. Number 3, nasolabial flap. Number 4, buccal fat pad. Number 5, microvascular free tissue transfer. So these are all the things that are there for free tissue transfer. You can go for soft tissue closure. These are all the options for larger reconstruction. So flap can be put for larger removal of bone. That is at your level. You remember that. That's it. If you are removing a segment, that is large segment as it is you are removing, you have to go for composite. What is composite? It has got bone plus cartilage plus muscle, all those things plus vessels plus nerve. All these things will be there. It is called as composite reconstruction. And microvascular free flap reconstruction. So microvascular is even vessel to vessel, you try to anastomose and then put a free flap. Mandibular defect is classified according to HCL OMS. Of course, it's not very important for you. PG level, it is not needed. Based on defects, you have to tell whatever the. So once again, any tumor, you have to go for resection, remove the tumor. Number 2, reconstruction. You have to construct with like. Number 3 is rehabilitation. Is a later thing. Rehabilitation. So remove the tumor and reconstruct with some other tissue. How do you deal the neck? Neck 1 to 3 nodes are involved. So elective neck dissection, when you are going to do a neck dissection till the level of T2 and with demonstrable bone invasion. For example, bone is very important factor, and 94% of the cases we have got bone involvement in this. So to go for 1 to 3 levels. So you have to go for removal of the tumor. Number 1, as you know, any tumor, removal of the tumor has to be done. Number 2, you have to go for removal of the neck nodes. Removal of neck nodes. Removal of neck nodes. Removal of neck nodes, you have to go for it. Neck nodes. So what do you do in that? It is called as neck dissection. It is called as neck dissection. Removal of neck nodes is called as neck dissection. 1 to 3 levels is being removed. So lesions on symphysis menti require bilateral neck dissection. Whenever midline structures, you need bilateral neck dissection. So staged neck dissection can be considered if primary tumor involves bone. Bone involvement is there, you can go for staged neck dissection. Extensive neck dissection, it should also involve level 5. So 1, 2, 3 only we were telling till now. Level 5 is posterior triangle nodes also to be removed. Posterior triangle nodes also removed. The presence of cervical metastasis. Extensive neck dissection sometimes needed. When do you give post-operative radiotherapy? Same thing. Positive margins in soft tissue or bone, multiple positive margins, and extracapsular spread, perineural spread, perivascular spread. All these things leads to post-operative radiotherapy needed for surgery plus post-operative radiotherapy is the treatment you have to write for this. Recurrence rates is 25%. Higher recurrence rate when it recur more, increasing T stage and positive resection margins. So it is common for all the tumors. T stage and positive resection margins, higher recurrence. Overall 5-year for lower alveolus carcinoma is 60% and disease specific survival being 70 to 80%. Cervical metastasis, I told you, decreases the prognosis by 50%. Okay, increasing T stage, particularly greater than 3 centimeters. Cortical bone involvement, cancellous bone involvement, these are all having bad prognosis. Bad prognosis, 3 centimeters, cervical nodes, and positive resection margins with decreased prognosis. All have got decreased prognosis, that is bad prognosis. Tooth extraction does not influence the prognosis. Tooth extraction and prognosis do not have any relation. So a small, this is only a favorable point for mandible. With this, we will complete this discussion on this one. So how do you deal the mandible? Is one important concept which we learn. This is not very important for you. Just I'm trying to, for completion's sake, I'm telling you. Mandibular alveolus almost 94% involve the bone, as we have seen. Okay, so in floor of the mouth cancers, buccal cancers, retromolar triangle cancer, they all involve the bone of the mandible. It is important in the management of the patient. Several questions are there, whether mandible has to be removed or not. How does squamous cell carcinoma invade the mandible? It invades the mandible either in invasive manner, it can be an invasive or it can be an erosive manner. Invasive, how does it go? It becomes fingers or islands with no osteoclastic activity. Invasive do not have any osteoclastic activity. Invasive is like fingers or bone islands. It goes like a fingers with no osteoclastic activity. Whereas in erosive tumors, It has got a broad advancing front with osteoclastic activity and connective tissue in the middle. So if this is like a finger, invasive, erosive is like a hand. Erosive is like a hand. It is a broad one. Erosive is a broad one. So osteoclastic activity is present. Here osteoclastic activity is absent. Invasive is like finger. Erosive is like broad, like a hand. It's like a finger. It's like a hand. So depth of the invasion increases, more invasive is the character. Okay. As the deep depth increases, it is more invasive. More invasive. Large, deeply invading tumors, invasive pattern. Deeply invading large pattern of tumors, they involve invasive. Invasive is like fingers. Invasive is like fingers. At the point of contact, the tumor enters the mandible. The tumor enters the mandible. Usually, the junction of attached and reflex mucosa. Wherever the mucosa is attached, mucoperiostum is attached and reflected mucosa. Whether it is edentulous or dentate, it enters to the point of contact. Point of contact. The mandible should be considered at risk at the point where the tumor is in contact. Wherever there is contact, the mandible is affected. Therefore, you have to plan for resection of the mandible. Fixation of the tumor is not necessary. Fixation is not necessary in bone invasion. The size and extent dictates the bone removal. It's not the anatomical features or invader or periodontal ligament. It is the size of the tumor and extent of the tumor which is very important. Preferential spread in the mandible. How does mandible get involved? Especially the inferior alveolar nerve. I was keeping on telling inferior alveolar nerve involved and medullary space is involved is rare, justifying 1 centimeter margin. If these are involved, you have to go for a removal of the mandible in a larger manner. So invasive pattern, if they are there like fingers, more likely to give cervical metastasis with extracapsular extension. Cervical metastasis with extracapsular extension is more common in the case of invasive pattern. As it goes deep and deep, it becomes invasive. There are no osteoclasts in invasive. How do we detect the bony invasion? You have to do imaging. So what do you do in that? It is called as orthopantomogram. 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 It is called as OPG. Orthopan. All the teeth are seen, all the mandible are seen, everything, my borders will be seen, everything will be seen. OPG tells us about the height, dental anatomy, dental pathology. Most commonly done by dental people. Plain radiographs just cannot detect the initial invasion until the 30% of the demineralization has occurred, giving rise to reduced sensitivity. So plain radiographs are not very useful. Therefore, you might have to go for orthopantomogram, which is also inadequate. Of course, the best thing is axial MRI with T1 stir fat suppression. This is called as the pattern that is needed for teeth. Axial MRI with T1 stir fat suppression. It has adequate specificity. And you have to go for bone scintigraphy. These are all the words that you should be trained in your